Hello, and welcome to today's webcast, Minimizing Bias in the Design of Cohort and Case Control Studies. Today's webcast is brought to you by the Discovery Network, the Critical Care Research Network at SCCM. My name is Drayton Hammond, a clinical pharmacy specialist in the Medical Intensive Care Unit and Cardiac Intensive Care Unit at Rush University Medical Center in Chicago, Illinois. I'll be moderating today's webcast. This webcast is being recorded, and the recording will be available to view again on the SCCM YouTube channel within 5 business days. There is no CE associated with this educational program. However, there will be an evaluation sent at the conclusion of the program. Your opinions and feedback are important to us as we plan and develop future educational offerings. So please do take just 5 minutes to complete this evaluation. A few housekeeping items before we get started. There will be a question and answer session at the conclusion of the presentation. If you'd like to submit a question, you can do so throughout the presentation just by typing in the question box located on your control panel. You'll also have an opportunity to participate in several interactive polls. When you see a poll, just simply click the bubble next to your choice, hit submit, and we'll hear the speaker have a discussion about the results. And now I'd like to introduce our speaker, Dr. Todd Miano, a critical care pharmacist and pharmacoepidemiology research fellow at the University of Pennsylvania Perelman School of Medicine. Dr. Miano earned his PharmD at Virginia Commonwealth University, a Master of Science in Clinical Epidemiology at the University of Pennsylvania, and currently he is in his doctoral program in epidemiology at Penn. His research leverages electronic health record data to develop large-scale projects to study drug effects in the critically ill population. And now I'll turn things over to our presenter, Todd. Please take it away.
Thank you, Drayton, for the introduction, and welcome to everyone who is joining us this afternoon. I'm very excited to be participating in this first of a series of webinars devoted to research methods in the critical care population. The goal of this series is to foster improved research among SCCM members by providing education on core research methodology concepts. As you might imagine, there's a tremendous amount of information that we could cover in this series, and so we really do appreciate your feedback at the end to highlight topics that you would like to hear more about to help us focus the content of future presentations. In this first session, we decided to begin at the beginning and review some of the fundamental concepts that apply to the 2 most common research designs that are available for critical care studies, that being the cohort and case control study design, and then to highlight some of the key sources of bias in these studies and to discuss some methods to reduce bias in all of these studies. And so let's get right to it. In the interest of time, we're going to start by comparing and contrasting the cohort and case control study design. Both of these studies involve the comparison of 2 or more groups. The key difference is how those groups are defined. The cohort study is defined by exposure status. A group of exposed patients is compared to a group of unexposed patients. These groups are followed forward in time and observed for the occurrence of disease outcome events. In this example, if exposure has an effect on the outcome, a protective effect on the outcome, we would expect to see a lower frequency of disease in the exposed group compared to the unexposed group. By contrast, a case control study, the groups are defined by disease status. We compare disease patients with patients who do not have disease and compare the frequency of exposure in the 2 groups. The comparison here is the frequency of exposure. So in this example, if exposure is again protective, we would expect to see a lower frequency of exposure in the disease group compared to the control group. And so it's important to highlight that for a given exposure and outcome pair in a given study population, the case control design and the cohort design are utilizing the same information, but just coming from different perspectives. Comparing the frequency of disease across exposure groups can provide the same information as comparing the frequency of exposure across disease groups. So this brings us to our first poll question. Consider this scenario. We are interested in studying risk factors for acute kidney injury. To address this question, we retrospectively identify 2,000 patients admitted to the ICU with sepsis. We identify patients with acute kidney injury and compare those to patients without acute kidney injury using all 2,000 patients in the cohort. And so the question is, what is the study design that is being used? And so here you would just simply choose cohort or case control. The answer is that the way that the study was set up is as a cohort study. So although we, in this example, are comparing patients with disease versus patients without disease, the key characteristic of a case-controlled study that was left out is that a case-controlled study uses all disease events or cases that arise from an underlying cohort, but a sample of the patients without disease. And so that sampling process is the key advantage of a case-controlled design. Given the same exposure outcome pair and the same study population, you can, by using this sampling approach, you can obtain estimates of the exposure outcome association using substantially fewer patients. So this is the key advantage of the case control design, and was actually the rationale for the folks that invented this approach back in the 60s and 70s. So in scenarios where obtaining the data involves substantial resources of time and or money, the case control approach can be very advantageous. So to discuss the analysis of these two designs, I'll begin with a cohort study and highlight the measures that we could obtain from a cohort study analysis, and then highlight how we can approximate these measures using a case control design. Because as I mentioned, the goal of a case control design is to provide the same information that you could obtain from a cohort study, just using a substantially smaller patient population. So analysis of a cohort study is based on the 2x2 contingency table, which I have highlighted here. This table allows us to enter in the distribution of disease events across exposed and unexposed groups, and we can calculate and compare risks in the population. So the risk or incidence of disease in each group is calculated by taking the number of disease events and dividing by the total number of patients in each group. After we have calculated risks, we can compare them to calculate the relative risk, which is simply the ratio of those two numbers, or subtract them to obtain the risk difference. As we'll see in a moment, we can approximate the relative risk from a cohort study using a case control study if we apply a cumulative sampling strategy. And as I mentioned, we'll discuss that further in a moment. We can also analyze rates in a cohort study by including person time in the analysis. To calculate the rate of an event in each group, we again take the number of disease events in each group and divide by the total amount of person time. So here, in the denominator is person time rather than persons. And as we'll see, we can approximate the rate ratio that we would obtain from a cohort study with a case control study if we employ an incidence density sampling approach. So let's go through a quick example. So this is the analysis of a cohort study. If we want to calculate risk, so let's first introduce the graph. So this is a simple study population where unexposed patients are on the top, exposed patients are on the bottom. Each line represents a patient, and the red axis represents disease events. If we want to calculate and compare risk, we would count the number of X's in each group and divide by the total number of lines. In this example, that would be 3/5 or 0.6 in each group. So over this study period of 8 years, we would conclude that there is no difference in the incidence of disease between the two groups. Now, with that being said, I would argue that most folks would still want to be treated in this example. So although the incidence is not different, the time to event does appear to be different. The patients in the exposed group look like they're living longer. If we want to quantify this, we can calculate rates. To calculate the rate in each group, we have to tabulate the total person time in each group. To do that, let's start with the first patient in the unexposed group. That patient here enters the study at time 0 and is followed for 2 years and then has a disease event. And so their total person time is 2. We could do the same thing for the bottom patient in the unexposed group. They enter at time 0, are followed for 7 years in the study, and then exit the study period. So their total person time is 7. So we would repeat this for all individuals in the study, and we could then calculate rates. So the rate in the unexposed group is 3 events over a total of 17 person years, or 0.18. The rate in the exposed group is 3 events over 29 person years, or 0.1. And so here we can see that comparing the rates allows us to quantify the difference between the two groups. So it adds an extra dimension of information to the analysis of the effects that we can obtain from the study population. So as I mentioned, we can approximate these measures with the case control approach. If we employ a cumulative sampling approach, controls are sampled at the end of the risk period, when this provides an estimate of relative risk that we would attain from the corresponding cohort study. If we apply an incidence density sampling approach, controls are sampled by matching on person time at risk, and by doing so, we can estimate the rate ratio. So let's go through an example of what I'm talking about here. So here I have a setup for a cumulative sampling approach. So again, this is a study population, and the red X's represent all the cases. And in this example, we are following patients for a total of 30 days. So to implement a cumulative sampling approach, we would wait until the end of the 30-day period and identify all the cases and remove them from the study population, leaving the patients without disease. From this group, we would simply take a random sample of the remaining patients, and we can then make our comparisons. So the key here is that all control patients have equal probability of being selected as a control. So regardless of how long they're followed in the study period, all patients have an equal probability. So it's possible that you could be comparing a case patient who was followed for 20 days with a control patient that was only followed for 5 days. So this approach ignores person time at risk. We can account for this using an incidence density sampling approach. And so essentially this approach repeats the sampling process multiple times for each event that occurs in the study population. So the first event in this study population happens on approximately day 7. And so at that time, we would select, take a random sample of the patients who are in the study period at that time and still at risk. And so we would find a control patient for this case that was also in the study period for at least 7 days. And so we would repeat this process for at the time of when each case occurs. And as patients fall out of the study, as patients are no longer at risk, they are no longer eligible to be a control. And so in this way, we are matching on person time, and we are able to estimate the rate ratio by doing so. Another important advantage of using the incidence density sampling approach is that it is better able to deal with time varying exposures, which are common in the critical care setting. So this is a key advantage of using this approach. I don't have time to expand on the reasons why, but this might be a good fodder for follow-up questions at the end of the session or on Twitter. To discuss the analysis of the case control study design, we have to introduce the odds ratio. So the odds ratio is the measure that we derive from a case control and that is used to approximate the corresponding relative risk or rate ratio from a cohort study. So what is the odds ratio? Well, we first have to talk about what are odds. And odds is a ratio of two probabilities. Whereas a risk is the probability of an event happening, odds is a probability of one event happening versus another event happening. So let's go through an example. We have a population of 10 patients that were treated, and there were 2 disease events, and so the risk is 2 over 10 or 0.2. To calculate the odds, we would take the 2 disease events divided by the 8 patients without disease. So the key difference here is in the denominator. To calculate a risk, it's the disease events over the total number of patients. To calculate odds, it's the number of patients with disease over the number of patients without disease. Or if we were looking at exposure here, it would be the number of patients exposed over those not exposed. So we could repeat this calculation for the treated and untreated groups and calculate a relative risk, which is the ratio of the 2 risks, or an odds ratio, which is the ratio of the 2 odds. And what we would notice is that both measures suggest that treatment is beneficial. The relative risk is below 1, suggesting a lower risk of disease in patients who were treated. The odds ratio is in the same direction. This will always be true. So if the relative risk if the relative risk is below 1, the odds ratio will also be below 1, and vice versa. When the disease frequency in the study population is low, these 2 numbers will generally be identical. An important caveat, however, is that if the disease frequency is high, the magnitude of the measures will be different. In this scenario, the odds ratio generally overestimates the corresponding relative risk. And what I mean by overestimate is that it will be more extreme. If the relative risk suggests a protective effect, the odds ratio will suggest a more protective effect. If the odds ratio suggests a relative risk suggests harm, the odds ratio will be, again, more extreme. And so the reason is that the scale of these 2 measures is different. So this is an important caveat to remember, thinking about what is the disease frequency in the population. And we'll come back to this idea in just a moment. So here I'm just showing an example of how we would calculate the odds ratio from the 2x2 contingency table in the setting of a case control study. And so we could, if you choose, could review this additionally at the end. So coming back to the interpretation of the odds ratio. So as I mentioned, a cumulative sampling approach, the odds ratio approximate relative risk, and this is only true when the disease incidence is low, and the rule of thumb that we use is approximately 10%. If we employ an incidence density sampling approach, the odds ratio approximate the rate ratio regardless of disease incidence. Because we're incorporating person time, the 2 measures are always consistent. And so this is another key advantage of using the incidence density sampling approach. It doesn't matter what the frequency of disease is in the underlying population. And so for this and other reasons, the incidence density sampling approach is viewed currently as the gold standard for case control studies, and I think that would certainly be the case in most applications in the critical care setting. So to close this portion of the discussion, I'd like to briefly discuss scenarios where one approach might be preferred over the other. As I mentioned, the key advantage of a case control study is that you can use a much smaller study population to address the same study question. And so in scenarios where there is substantial manual data collection from charts, let's say you are interested in studying acute kidney injury, and you're doing this retrospectively and it takes you an hour or more to collect data on each patient, if you can use, for example, 600 patients rather than 1,500 patients, that's a lot of hours saved by using the case control approach. We often think of using case controls in a retrospective setting, but we can also implement them prospectively as we do for cohort studies. So again, let's say that we are interested in studying acute kidney injury, and our key exposure of interest is a novel biomarker that is very expensive to measure. Each test costs, $1,000 or $2,000. And so using a case control study, we could spend a lot less money to do our study. We can enroll patients into our study prospectively and take samples of blood for all patients in the study, and then observe patients as disease events occur, employ incidence density sampling for each case, and then only run the samples in the cases in the sample of controls. So the case control study design, I think could often be beneficial to address many critical care questions, and I think we should consider using this approach more often. If resources of time or money are not a key issue, if we're doing a large database study, for example, the benefits of the case control design are not as apparent, and so there may not be really any reason not to use a cohort study. There isn't any information that a case control study that can provide that can't be obtained from a cohort study, and additionally, you can measure the incidence of disease using a cohort study, and so if that is a key question, then the cohort study is really the option that would be preferred. So at this point, we're going to switch gears. We kind of reviewed the key concepts related to the two study designs. And so now we're going to talk about where we can go wrong, sources of bias when employing these approaches. When we talk about bias, we generally think of these three broad terms, three types of bias. And when I say bias, I mean systematic error in the study. The three types of bias include confounding, selection bias, and information bias. And so for today's discussion, in the interest of time, and because it's one of the most important and common sources of bias, we're going to focus most of our discussion on confounding. So to begin, what is confounding? The term confounding, I think, is frequently used to discuss studies and journal clubs and whatnot, often to mean a variety of different sources of quote-unquote badness in a study. But it actually has a very specific meaning, and it can be thought of in two ways. The first is a lack of comparability, differences in baseline risk for the outcome. So are we comparing apples and oranges? Are the treated patients systematically sicker than untreated patients? Another way to think about confounding is as a mixing of effects. The exposure effect is mixed with the effect of an extraneous variable. And so often what is happening is that the difference in baseline risk factors between the two groups is what leads to the mixing of the effects of those factors with the exposure of interest. Confounding is produced by confounders. A confounder is a variable generally with the following properties. It's associated with outcome, associated with exposure, and not on the causal path from exposure to outcome. And that third requirement has to do with differentiating a confounder from a mediator. So for our discussion, we're going to focus on these first two characteristics: associated with exposure, associated with outcome. This figure at the bottom is the classic way of representing a confounding relationship. And we can think of a confounder as being a common cause of exposure and outcome. A classic example stems from the early literature examining the risk of smoking on lung cancer. In some of those early studies, investigators noticed that patients with lung cancer more frequently had yellow fingernails compared to patients without lung cancer. So to set this up in our figure, the exposure E would be yellow fingernails, the outcome D would be lung cancer. And our question is, we're noticing that yellow fingernails is more common in patients with lung cancer. Is there any way that the color of the fingernails could be affecting disease risk? Well, another question is, well, is there another factor that we're not considering that could be causing driving the association between these two? And in this example, the confounder would be smoking. Smoking causes you to have yellow fingernails. It also causes you to have lung cancer. And so the apparent association between fingernail color and lung cancer is being driven by the common cause, which is smoking. Here's another way to view this. So this is a hypothetical example of a study that is comparing the rate of bleeding in patients receiving oral anticoagulation with either warfarin or dabigatran, which is one of the novel agents. And so what I'm representing here is that the rate of bleeding, the observed rate of bleeding, is higher in patients treated with warfarin compared to patients treated with dabigatran. So we might infer that dabigatran is beneficial here in terms of bleeding. Now, what if I were to tell you that warfarin patients at baseline appeared to be sicker? They were older, they more frequently had renal dysfunction and hypertension, and all of these factors are risk factors for bleeding. If that were the case, we would be concerned about confounding in this scenario. And so some of the increased incidence of bleeding that we are observing here may not be due to the drug, but the effect of the higher prevalence of risk factors. So the effect of those factors is mixed with the effect of warfarin. So if we were able to differentiate the proportion of disease due to each risk factor in each group, our figure might look like this. So here, the different color shadings are representing the amount of disease due to that given factor. And so if all of these various risk factors are more common in the warfarin group, the higher incidence of disease is due more so to the higher prevalence of risk factors and not to an effect of the drug. And so if we could control for the effect of these confounders, we can isolate the effect of the drug. And in this example, after controlling for the confounders, there doesn't appear to be a difference. And so this is the essence of the goal of analyses that aim at controlling for confounding. We're trying to isolate the effect of the exposure. There are a variety of methods that we can use to achieve this. For today's discussion, we're going to focus on propensity scores and regression techniques because they are the most common. The gold standard for reducing confounding is randomization. And in fact, it's the gold standard for removing confounding, and is really the only benefit of employing randomization is to remove confounding. It doesn't really provide any other benefits in terms of removing bias. Randomization removes confounding by ensuring that all patients, regardless of their baseline characteristics, have an equal probability of receiving treatment. That removes the arrow from any confounder and exposure. So it blocks the association between confounders and exposure and thus controls confounding. Propensity scores are based on the same idea, balancing risk factors between groups at baseline. Regression analysis is based on modeling the outcome and blocking the association between potential confounders and disease. So we'll start with regression. As I mentioned, this is one of the most common approaches used to address confounding. There are various types of regression models depending on the outcome that is being analyzed: linear regression for a continuous outcome, logistic regression for a yes-no, Cox models for time to event. Importantly, the underlying mathematics and how these models are built is actually quite similar across the various models. A multivariable regression model is what's most often used, and is simply an extension of the simple y equals mx plus b paradigm that we learned in middle school algebra. So if y is the outcome and this x is the predictor, this equation allows us to examine the change in outcome for a 1 unit change in exposure. Multivariable regression works the exact same way. It just includes multiple different predictors of outcome. So it allows us to construct outcome models that include the exposure of interest and the various confounders that we might be concerned about. So if we have an outcome model that includes the exposure of interest and all the potential confounders, it provides an estimate of the relation between exposure and outcome, holding all other variables in the model constant. And in that way, it can control confounding from those variables. The key limitation of regression models has to do with overfitting. Essentially, if there are too many variables, we can kind of overwhelm the ability of the regression model. There's an upper limit on the number of variables that can be included. This it was one of the key rationales for the development of propensity scores. So whereas regression models focus on the outcome, propensity scores focus on exposure. It's a model that provides the probability of receiving treatment based on observed characteristics of the patient. And it's based on the recognition that treatment decisions often are based on many different factors related to patient prognosis, and many of which might be confounders of the exposure outcome association that you're interested in. So the idea is to incorporate all this information, all the factors that influence the treatment decision, into a model that summarizes this information in a single probability. And so the goal of propensity scores is to compare outcomes in patients that have an equal probability of receiving treatment. So we summarize all this information into one number. And if we compare patients with equal probability of treatment, the genius of the propensity score is that it balances all the factors that went into the development of that probability. So controlling for the propensity score mathematically is the same as controlling for all of the variables that went into that model. So a very powerful approach to summarizing that information. There are two steps involved in propensity score analysis. The first is to calculate the probability of receiving treatment. This is often done with a logistic regression model. Once we have that probability, that score can be used in the design and analysis of the data. The most common use is to match patients on the propensity score and compare outcomes in the matched group. But there are many other ways that it could be used that we don't have time to build upon here. But the take home, as I mentioned, is that matching on the propensity score balances all covariates that are entered in the propensity score model. So this brings us to our second poll question. Given the same set of covariates, propensity scores are better at controlling confounding compared to regression models. So our choices are yes, this is generally true, no, there's really no advantage of propensity scores, or it depends. So given the same set of covariates, our propensity score approach is better than regression approaches. So are propensity scores inherently better than regression models? And the answer is that it depends, as you might have surmised. So there are studies that have compared the two approaches in the same study population to see, do you get different answers? And so most often, given the same set of covariates, the methods will produce similar results. There is a key factor that can be used to decide between propensity scores versus regression analysis. This is related to the issue of overfitting regression models. There is a limited number of covariates that can go into any regression model. The general rule of thumb that is used is there must be 8 to 10 events per variable entered into the model. So if we have 100 patients and 40 outcome events, we can include at most 5 variables into the model for a ratio of 8 events per variable. So that's a rule of thumb that is used. There are more recent studies that suggest that maybe that rule of thumb can be relaxed, but regardless, that's what's most commonly implemented. If we have more covariates to control for than 5 in this scenario, if we enter in more than 5 covariates, the regression models become biased. They give us incorrect point estimates and incorrect standard errors and p-values. So there's at least one simulation study that compared the two approaches, varying the number of events per variable, and they concluded that the propensity score is less biased when there are 7 or fewer events per variable. Regression analysis may actually be less biased when there are 8 or more. So there's at least one study that gives some guidance on how to choose between the two approaches. But as I mentioned, given the same set of covariates, often the two approaches will provide you the same answer. So this brings up question 3. Are propensity scores like randomization in that they can control both measured and unmeasured covariates? So is there something special about propensity scores? They're sometimes termed pseudo randomization. So is there anything special about propensity scores here? Okay, we have some results. I'm very excited, and I'm very excited by the results. So the answer is false. Propensity, the only way to control unmeasured variables is through randomization. So the key point here is that propensity scores share the same limitation as regression analysis. You can only control for variables that are measured and included in the model. So we've talked about a general discussion of confounding. Let's go into a specific source of confounding that is quite common in studies in the critical care literature, but hasn't received, I think, enough attention, and that is the healthy user effect. So this phenomenon was first observed in this study, the Coronary Drug Project from 1980. This was a randomized controlled trial that compared a lipid-lowering drug, clofebrate, with placebo, with the outcome being 5-year mortality. And the overall study results were negative. And so they conducted a series of subgroup analyses to see why the drug failed. And so this is a subgroup based on adherence. And what they observed is that if patients had better adherence, if the risk of mortality was substantially lower. And this makes a lot of sense, right? The drug could only work if you take it. And so this might be a good explanation of why the drug failed. This explanation, however, is less tenable when we do the same thing in the placebo group. So if patients were more adherent to placebo, again, substantially lower mortality. And so this suggests that the difference in outcome is not being driven by the drug, but by the fact that patients who are adherent are different fundamentally from patients who are not adherent. And importantly, they were unable to adjust away this effect by any multivariable adjustment. So this is a powerful source of confounding that can be difficult to control with standard methods. Statins, and so this has been seen very commonly in studies of statins. And so this is a study that specifically means to explore this healthy user effect. So in this study, they compared patients who were adherent, had good adherence to statins, or poor adherence to statins. And they looked at the incidence of a variety of outcomes that you wouldn't have an a priori hypothesis that statins should reduce. Burns, car crashes, poisonings. How could statins reduce the incidence of all of these effects? And so a more likely scenario is that adherent patients are different from patients who have poor adherence. So what is going on here? So as I alluded to, healthier patients are generally more likely to initiate drug therapy and stay on the drug therapy. And this is particularly important in studies examining the effect of drug classes used for primary prevention. And so we commonly see these types of studies, patients on statins, aspirins, various antihypertensive, anti-diabetic agents. We compare patients that were on these drugs or not at the time of ICU admission and look at outcomes. And so in each one of these studies, we have to be thinking about the healthy user effect. So consider these two patients. The first has a good job, is punctual, organized, exercises and eats healthy, drinks infrequently. The second patient also has a good job, but is disorganized and forgetful, doesn't eat healthy, doesn't exercise, sometimes drinks to excess. So lots of behavioral differences here. And so I would ask you, which patient is more likely to initiate a statin for primary prevention of cardiovascular disease? Which patient is more likely to adhere to it? And I would argue that the first patient is probably more likely. And so the point here is just to highlight the types of differences that could lead to using a drug versus not using a drug that may be related to prognosis and that are difficult to measure. So all these behavioral factors are often not in a critical care database. And for that reason, it makes it very difficult to control for this healthy user effect. As I mentioned, statins are the poster child for this. So here I'm summarizing data from a variety of studies that where in observational studies there's suggests a hypothesis of a benefit of statins on acute kidney injury, ARDS, COPD exacerbation, and most recently delirium. In each case, the hypotheses were refuted in subsequent large randomized controlled trials. And so a plausible explanation here is, and so in all these studies are comparing patients admitted to the ICU on statin or not prior to admission. And so the healthy user effect is operating potentially in each one of these examples. So how can we control the health user effect? So in theory, if we can measure, control all variables related to health status and behavior, we can control it with regression, but that's typically challenging to do, as we discussed. Two potentially more effective approaches are to use an active comparator group and or a negative control outcome. The idea with the active comparator is if, for example, we're interested in a statin, we would compare statin patients not to unexposed patients, but to patients taking a different lipid lowering agent, with the idea being that the healthy user effect should be operating in both groups, and so we can kind of match on the healthy user effect. The idea with the negative or control outcome is that if you look at an outcome that you don't expect to see an effect of the drug on, it gives you a signal to how important the healthy user effect may be. So if we see a difference in the control outcome, we're less confident in the results of the primary analysis. So here's just a recent example examining calcium channel blockers and outcome in sepsis. The two studies used very similar approaches: 30-day mortality in patients with sepsis, propensity score, matched analysis. The key difference is that the study on the left compared treated versus untreated. The study on the right compared treated versus patients on an active comparator, beta blockers. And so one study shows a 40% relative risk reduction, the other a 6% relative risk reduction. And I would argue that the 6% estimate is likely doing a better job of dealing with the health user effect and is more plausible. And so now we'll move on to the last source of bias that we'll talk about, which is a mortal time bias. This is one of my favorite types of biases because I think the name is so cool, immortal time. So what exactly are we referring to? Immortal time refers to a span of time during which the outcome under study could not have occurred. It usually occurs when the passing of time before a subject initiates a given exposure. So to the extent that there is a delay between the diagnosis of treatment diagnosis or hospital admission and the initiation of an exposure, we can create immortal time. This bias often can cause spurious protective associations. So it often builds in a survival advantage for exposed patients. So let's illustrate this with an example that I actually came across on Twitter. So this is officially my the first Twitter citation in a scientific discussion. So let's assume that you love eating Cheetos, you eat them every day, and as a result of extensive research online, you've convinced yourself that there are actually health benefits of eating Cheetos. The particular mix of cheeses used are a good homeopathic treatment. To explore this hypothesis, you examine the effect of eating Cheetos on patients admitted to the hospital with myocardial infarction. So you identify patients with MI at the time of admission to the hospital, and you follow them for 90 days after hospital admission, and you observe which patients eat Cheetos and which patients do not, and you compare mortality risk between those two groups. And as I mentioned, you start following patients at the time of admission. If we approach this question in this way, what you would likely see is a lower risk of mortality in the patients who go on to eat Cheetos versus those that do not. And it's not because Cheetos are effective, it's because we have created immortal time bias. To eat Cheetos, a given patient has to live long enough to consume the Cheetos. And so in that way, we are building in an advantage for the patients exposed versus unexposed. There's no such survival requirement observed in the patients who do not eat Cheetos. And so we're building in a survival advantage here. And so we could replace Cheetos in this example with any other treatment that you have to survive long enough to use. And so this can easily lead to spurious associations of various treatments. So this is a classic figure that is used to describe the bias. So the top line is an exposed patient, the bottom line is an unexposed patient. And so the study, assume that the study start date is the time of hospital admission, and on the top portion, the red line represents unexposed time that occurs before exposure starts, that is immortal time. And so this is a built-in survival advantage that we have created. So there are a variety of scenarios that can create this bias. So here are just some examples. Effective antimicrobial de-escalation of mortality in patients with sepsis. You have to survive long enough to receive de-escalation. Effective MRSA infection on hospital length of stay and cost. You have to survive long enough to develop infection. Patients without that infection have no such requirement. So immortal time bias can be very common. How do we deal with it? The gold standard is to treat exposure as a time-varying covariate. So coming back to our example, we have this portion of time in the unexposed patients before treatment begins that is unexposed time that is immortal. And so we simply treat unexposed time as unexposed. So this time goes into the denominator for patients in the unexposed group. And so this is the standard approach. If there's an active comparator, so if there's a drug that we can use that is used for similar indications, then we have a natural time zero for both groups. And then this way we can also reduce immortal time bias. But this assumes that we have an option, an active comparator that is used for sufficiently similar indications. So this is our last poll question. Consider this example. Our objective is to determine whether antipsychotic treatment reduces mortality in mechanically ventilated patients with delirium. To address this question, we designed a cohort study that compares patients treated with quetiapine versus those not treated. Follow-up begins on the day of treatment for those that received quetiapine. Follow-up begins on the day of delirium diagnosis for the unexposed. And so the question is there immortal time in the study design? No, because follow-up begins at the time of treatment, and the exposed group, or yes, because a different time zero is applied to each group. So what do you think? Is there immortal time here? So fantastic. So everyone is choosing yes, there's immortal time, and so that's either because you understand immortal time bias, or it was just pretty easy to guess that the answer was going to be yes. Either way, let's go through an example just to highlight. This again is just a study setup where unexposed patients are on the top, exposed patients are on the bottom. The squares represent the date of delirium diagnosis, that is time zero for the unexposed group. The circles represent the date of treatment initiation for the quetiapine group. We can calculate the rates and a rate ratio of 0.55. So the key here is that everyone who was treated also had a date of delirium diagnosis, and the time between diagnosis and treatment initiation is by definition immortal. And so to deal with this, that person time, there's a total of 11 person days of immortal time, needs to go into the denominator of the control group, and by doing so we can correct for the immortal time bias. This is a really great paper that shows immortal time bias in an actual patient population by the group at Vanderbilt. So I highly recommend reviewing this as an illustrative example. And so we're at 10 minutes to the hour, and fortunately we are at my last slide. And so I'll close here, and I'd like to thank everyone who joined us and thank the Society and the Discovery Network for sponsoring this, and we will hopefully be able to discuss a few questions.
So thank you so much, Todd, for providing a really great sort of beginning conversation, first of our 3 sessions for this entire year through the Discovery Network. I think we see a couple questions coming in, but we do have about 8 to 10 minutes to take questions. So I'll start with one that I see here. In particular, Todd, it deals with your discussion on cohort and case control study design. Can you comment on the challenge of identifying appropriate cases and maybe how best to do this in practice if you're looking at this type of study design?
Oh, great. Well, that's a great question, and that's in fact the key. That's a key aspect of designing a case control study, and so I think it's useful to always think of a case control study as being nested in the underlying cohort. So in terms of so the key is to appropriately identify the source population of the cases. So we want to sample our controls from the source population that gave rise to the cases, and we want to select cases in such a way that the probability of being selected as a case is independent of exposure status and independent of disease status. In the outpatient setting, where these studies are more commonly used, that can be very challenging because it's often not clear what the source population is. But in the critical care setting, I think it's often more clear. So clearly thinking about what is the source population. So let's consider an example. I conducted a study where I was interested in comparing the rate of venous thromboembolism in patients exposed to enoxaparin or dalteparin in the trauma population. So I employed a cohort design to address this question, but I could have employed a case control design. And so the first step would be to clearly enumerate what is the source cohort that I'm interested in. So I would create the underlying population by identifying patients exposed to enoxaparin and dalteparin and identify the dates and times of when treatment begins and when treatment ends for each patient, and in that way enumerate the underlying cohort population, and then at that point identify cases and sample controls. So that's just one example of hopefully to highlight the process for thinking about what is the source population.
So that's really helpful. I know I've seen more of these in recent years, so it's great to just think about how best to do that so we don't have those concerns about believing the data we read in these case control studies. I do have a question that came through looking at when you were talking about overfitting or inadvertently overfitting regression models. How do we recognize that maybe we've done that, or what's a good way to think about that process so we don't commit that potentially really detrimental error?
Yeah, so so a great question, and overfitting is a key issue. If your regression model is overfitted, it's going to provide you incorrect answers. And so generally, using the rule of thumb of 8 to 10 events per variable, is helpful. There are methods studies, simulation studies that show that is kind of the rule of thumb that where bias starts to occur. And so once you've determined the number of patients in your study that have an outcome, you can simply, divide that number by 8 to 10 to identify how many covariates can go into the model. Oftentimes there are more covariates that you want to control for than you can include, and so this is the rationale for kind of the two-stage process of developing a regression model. The univariate screening approach to identify variables that go into the regression model. So in the first step, we're not sure which variables may in fact be confounders, and so we can screen a long list of potential confounders, identify which variables have an association with outcome in the first step, and then include that smaller list of covariates in the multivariable model. So that's one common approach that can be used to try to reduce the number of variables that go into the final model.
Yeah, can you maybe talk about how we consider, like, when we're doing that screening, potential collinearity, like if you had SOFA and Apache come out, but you think that those are very related to each other, and then maybe also a follow-up, what you would recommend we consider with our cutoff for p-values, 0.1 or 0.2 from the univariate to put into a multivariate?
Yeah, so these are really great questions, and perhaps this could be an entire additional hour-long session. So in general, there are automated ways where you can put all the variables into your analysis program, and it can do the selection for you. And those are frowned upon because it's kind of blindly following the numbers. And so issues about collinearity and things that you mentioned, the computer's not considering all those factors. So the model building is a stepwise process where you're not only looking at the estimates from the model, but you're thinking about the research question and thinking about the plausibility of the variables that are going into the model. So that's the first thing that I would say, is that model building is very much contingent on your subject matter knowledge. You have to understand the variables that are going into the model. And then there are generally two ways that you can screen. You can screen variables in the univariate step based on p-values for each variable and outcome. And so there are actually simulation models that provide guidance here. So generally higher p-values, 0.2 or 0.25 or what's recommended, because in a univariate setting, a variable can cause confounding without being significantly associated with outcome. So in the first step, use a more lenient p-value as a screening step. That's been shown to reduce confounding compared to using lower p-values. So generally higher p-values are better. 0.25 is kind of what's most often used. Another way to screen covariates is to use a change in estimate approach. So instead of screening by p-values with outcome, you perform a series of outcome models where the only variable in the model is exposure, and then you enter in each potential confounder one at a time with exposure, and the variables that change the point estimate for the exposure of interest are then potential confounders. And the rule of thumb that is used there is when the exposure point estimate changes by 10 to 15%, that suggests confounding. And so you can screen variables in that way as well. And for me, I think that's more intuitive in terms of confounding. The essence of confounding is a change in the point estimate of with the inclusion of the confounder. So I think that the change in estimate approach is more directly screening for confounding. So, but either of those methods can be effective.
Great, thank you. We had a couple more questions. Maybe we can run through two of these quickly. Can you explain how to control for a mortal time bias in terms of how this looks on the statistical analysis?
Yes. So as I mentioned, the key is to treat exposure as a time-varying exposure or time-varying covariate. And to do that, your analysis has to be based on person time and not person. So it's difficult to do this with a logistic regression model, for example. So generally, you have to employ a Cox proportional hazards model, or you could use a Poisson regression model. But either approach would allow you to The analysis is based on person time, and you could then, for a given patient, divvy out this portion of follow-up was exposed and this portion of follow-up was unexposed, and the model can incorporate that information. So you would enter in a time-varying covariate in either one of those models.
Wonderful. We definitely see a need for that, and especially in critical care research.
Absolutely.
I think we're out of time, but I would strongly encourage those who do have questions. Todd has his email on there, todd.miano@uphs.upenn.edu. Or even, is it fair for them to reach out to you on Twitter if they think more people would want to learn than just them?
Sure. Yeah, I think that would be a great platform to kind of foster greater discussion.
Great. At Miano81, it looks like. Thank you so much to everyone who tuned in today. Please look for follow-up email with a link to complete an evaluation. Again, there's no CE associated with this. However, we do want your opinions and feedback as we look to grow this program throughout the end of this year and into 2019 as well. So thank you, everyone. That concludes our presentation for today.
Thanks, everyone.